Good morning, good afternoon, and good evening, ladies and gentlemen. So first of all, I would like to introduce you a little bit about myself. My name is Ngọc and I'm from Hanoi, Vietnam. And it is my pleasure for me to be the master of ceremony on this very special occasion, the third Asian Congress of Neurosurgical Nurse Webinar. And on behalf of ACNN, I would like to extend a very warm welcome to Professor Joko Kato from Japan, the patron of ACNN, Matron Yi Cheng from Malaysia, the president of ACNN, all speakers, chairs, commentators, and audience. ACNN webinar is part of the ACNN activities with the aim to share knowledge and skill as well as update nurse with the latest nursing management for neurosurgical patients. And for the webinar today, I would like to introduce our distinguished speakers, Professor Dr. Vinko Dolenc and Dr. Andrea Styner. And for our guest today, I would like to introduce first Professor Antu Goel, Professor and Head, Department of Neurosurgery, Lilavati Hospital and Research Center, Bandra, Mumbai. Professor, Department of Neurosurgery, R.N. Cooper Hospital and Medical College, Mumbai. Professor, Department of Neurosurgery, Mumbai Hospital Institute of Medical Science, Mumbai. And I also would like to introduce the second chair, Ms. Annie Mujasi, Chief Nurse, National Brain Center, Jakarta, Indonesia. And for our commentators today, we have the first Professor Hirotoshi Sano, Emeritus Prof. Fujita Health University, Vice Director Advisor, Singawabasi Hospital. And the second commentators, I would like to introduce Professor Vladimir Benes, Chairman in Clinical Neurodiscipline Central Military Hospital, Prague. First Medical Faculty, Charles University, Prague. President, International Academy of Neurosurgical Anatomy. And the third commentators, Professor Mahmoud Qureshi, Chairman, Neurological Society of Kenya, President of CAANS. And I also would like to welcome our special guest, Professor Akihide Kondo, neurosurgeon from Tokyo, and Professor Arian Musabeli, consultant and CEO partners in healthcare clinic and foundation initiative of medical service for underserved and remote communities of Mat County, Albania. And before we start our webinar today, I would like to call upon Professor Joko Kato to deliver her opening remarks. So Professor Joko Kato, it's time for you.
Hi, everyone. Japan is 7 p.m. now. Thank you very much for joining our webinar, especially today's so wonderful guests and also commentators and also the chairs. First of all, I would like to congratulate Dr. Matron Yi. She organized what a wonderful webinar for all nurses, and also today is maybe the nurse practitioners. And we are very much looking forward to their lectures. Thank you very much.
Thank you, Professor Joko Kato. And now may I call Matron Yi for say some few words.
Good morning, good afternoon, and good evening to all. I'm very delighted because a lot of support from all over, especially Professor Joko Kato and the rest of the neurosurgeons from all over always give us full support. Thank you very much. And this is our third ACNN webinar, and I hope we will continue to carry on the webinar. Thank you very much once again. Thanks. Now I would like to call upon Professor Goel to introduce Professor Vinko.
Yeah, thank you very much. Can you hear me?
Yes.
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 Okay. So it is my absolute pleasure and delight to see all the distinguished faculty and guests on the screen, particularly my dear Yoko Kato, who is the absolute inspiring leader of world neurosurgery. And I'm sure she has done great for not only neurosurgeons, not only for senior neurosurgeons, not only for neurosurgeons in developing country, but all over the world. And also I know of her contributions to the nursing, the way she has contributed, the way she has trained my own nurses from India, from a public hospital in her department. My nurses still remember the wonderful time of learning that they had with Yoko Kato and her team. So, needless to say, nursing is an important constitute of all hospitals and all doctors' life. A good nurse can make a difficult operation simple. A good nurse is absolutely important to conduct any neurosurgical work, whether it is in the ward, whether it is in the theater. If the nurse is not to the liking of the neurosurgeon, to the mental framework of the neurosurgeon, the entire operation can go mock. When we enter into the world of medicine as a doctor, as a young doctor, it is the nurses who train us. As we develop into a young fellow and later into experienced surgeons, it is the nurses who are our partners and our trainers. So no question, the companionship of nurse and a neurosurgeon in particular and doctors in general, absolute, everybody knows there is no need to lecture on this subject. My work today that has been assigned to me is to introduce a giant of a neurosurgeon, a giant of human being, a giant of a person in size also, and in personality also. He looks like a Hollywood star, absolute wonderful human being, Professor Vinko Dolenc. Every neurosurgeon in the world knows this small little name from a small little country, from a small little city, who shook the world of neurosurgery by his contributions from a small town to the whole world on cavernous sinus, on skull-based surgery, on fine microneurosurgical techniques, how to do surgery without any fuss. He's he does not look that old, but he's working in complex neurosurgery since 1969, I understand. And then he developed from a young man to a senior man, to a more senior man, to an absolute legend, and now a mentor to so many neurosurgeons all over the world. We all know as neurosurgeons his contribution in skull-based surgery, contributions in cavernous sinus surgery. You see, cavernous sinus, nobody in the world knew what is cavernous sinus. Nobody in the world could believe that you can actually go and clip aneurysm within the confines of cavernous sinus. There were, of course, some giants like Tapters, like Parkinson, and some other people, but what Vinko did, Vinko combined the anatomical work of all these giants and then formulated his own strategy. He was the one who really convinced the world, convinced young and senior and very senior neurosurgeons, even the giants of his time, he convinced that intracavernous sinus surgery is really possible. Intracavernous sinus surgery is really safe and a doable thing. You see, he avoided bypasses for such aneurysms, which were quite difficult at that time, 30, 40 years ago, and also to do aneurysm within the confines. As a young neurosurgeon, I was influenced by his work and tried various. I know how difficult it is. I know how complex it is. What Vinko did from a small little town of Ljubljana continued to progress in his field of cavernous sinus surgery, continued to showcase to the world how to do cavernous sinus surgery. His anatomical work is par excellence, and his experience as he went on doing surgery after surgery after surgery, he showed the whole world. I think his work, what he shows even today, the work in the past, nobody has ever been able to match that kind of beautiful surgeries that he showed and he demonstrated to the world. Absolute giant in the field of skull-based surgery and a good friend for several. So in 86, I believe he conducted one very huge symposium on cavernous sinus surgery in Ljubljana. And then 20 years later, he conducted another huge symposium as to what has developed after the initial contributions in the cavernous sinus surgery. And in 2006, I was very fortunate to give 3 lectures in this very important symposium. I think that was one of my most important conferences that I attended. Vinko Dolenc, to say Vinko Dolenc is an absolute gem of a person, brightest, smartest, handsome, beautiful microneurosurgery that he has shown to the world. And I'm sure he will dictate to us, show to us how his association with the nurses helped him in developing this wonderful career, in developing cavernous sinus surgery in particular, skull-based surgery in general. It will be an absolute wonderful event for me to hear what he has to say about his coordination and collaboration with nurses through his wonderful giant career. Vinko, are you there, Vinko?
First of all, thank you very much, Atul, for your wonderful words. I don't deserve it, so much. So first, when I was invited to talk about this topic, I said, okay, fine. Finally, I will be able to tell something about our wonderful, needed scrap nurses, neuro nurses, whom we owe so much and for their indispensable help. But then I started to formulate it, and I said, my gosh, it's not for a single, doesn't work again. It's not only for the single lecture. Next one.
Ja, det.
No, it doesn't work.
Ona ne deluje.
Okay.
Pritisnite
I said, this is not for a lecture. This is for the whole book. How can I describe everything? Then I decided, okay, I will talk only about my personal experiences at hometown and what I did experience in the different countries. As you said, here in Ljubljana, we started with cavernous sinus. Nobody believed it. And that's why my duty was to go to different places around the globe and to show how it works. And of course, after the lecture, I did also with a team in those hospitals, the live surgery. So I was working with nurses, scrap nurses of different places, in different places and different hospitals, in United States, in Japan, India, China, Europe. So I was able to study how it works. But neurosurgery has made a wonderful progress in last 100, 120 years, from the beginning to the recent organization. First of all, neurosurgeons, our teachers, they had to fight to be recognized among the other surgical professions. Neurosurgery, this was just at the side. Then it started slowly, slowly, and then quicker and quicker to come to the nowadays organization. As I see the role of neuro nurses is in preoperative, which is different from post-operative, and also very, very different from scrap nurses, neuro nurses at surgery, which is the most important. Nowadays, well-organized process of treatment of neurological patients consists of 3 steps: admission to the neurosurgical department, diagnostic procedures. In this part, neuro nurses are playing very important role. Then surgery itself, or even more surgeries, scrap nurses at the operations is the most important part. And then also after surgery, because even when the surgery goes well, the post-operative care in neurosurgical intensive care unit and step-down intensive care units is very important. Then post-operative patients stay in the department needs a lot of explanations to the patient. And then maybe also neurorehabilitation and post-treatment follow-up. And these are different roles of neuro nurses at each this segment of treatment. Pre-operatively, how to overcome the patient's fear? The patient is afraid. Does the surgeon's explanation is enough? Do we need also psychologists? But we certainly need neuro nurses who are always with the patient. It is like to be married with the patient, and questions are occurring again and again. Neuroanesthetists visit the patient once, maybe twice before surgery. But what we found, very good method was also to meet the patient who is waiting for surgery with a patient treated before for the same disease. Patients, they believe to the patients more than to medical staff in the hospital. Who has or who have to communicate with the family? Neuro nurse coordinator, surgeon, anesthetist, psychologist. Again, here, the family does believe to neuro nurses the most. For that reason, their responsibility is really very high. Important factors in the discussion is pathology of the patient, his or her psychoeconomic factor, the religion, and the age of the patient. What does it mean? It means that neuro nurses have to be familiar, have to know what pathology is, and then get information from the family, what kind of socioeconomic situation they are in, what religion, and so on. Frightened patients, frightened or terrified patients are not good candidates for surgery. I was always reluctant to operate on a patient who could not calm down, who could not believe that surgery is needed and will be good. That's why patient and surgeon have to go hand in hand against the disease. Surgeon cannot go into the operation just ordering the patient that he will do what is necessary. The patient has to believe. But how? How this can be achieved? First duty is at neurosurgical surgeon side And that's why neurosurgeon has to study, practice in the anatomy lab before go to the operating room. Nobody is allowed to kill patients to learn how to operate his or her own family members good. So why not to go to the anatomy lab? This is essential. Prior to surgery, the patient has to reach the confidence into the team. And here, again, the greatest task is on the neuro nurses. They have to be friendly with them, to explain to them in the patient's language what they are heading to. So prior to surgery, the patient has to cope with the fear successfully. We know that fear is very difficult to control. The patients have a different fear. One is more fearful, the other one is less. But this depends on the belief to medical stuff. And that's why it is so important, the common language of the entire staff, which is a must. Nurses and other staff, they have to talk about the disease, about the situation, in the same language as the surgeon. So they have to be informed. And that's why they do study this. Now, explanation to the patient. What to expect from surgery when the patient has benign pathology, malignant, aneurysm, or AVM? It's different. And again, the nurses do need complex knowledge of these diseases and situations. All the information to the patient should be positive, but correct. Patient may ask the question, is it cancer? The nurse has to answer, no, we don't know. We have to wait to pathohistological diagnosis to find the correct complementary treatment when necessary. So the nurses have to tell to the patient the right answer, which allows them to extend this to the additional treatment later on if necessary. So the patient will not create more fear. The surgeon has to say, or in this way, that with almost complete tumor resection, the complementary treatment, if needed, will be more successful. So again, the patient is activated. And in this way, the surgeon and neuro nurses, they have to go the same direction, the same explanation. Now, neurosurgical operation is not a one-man or one-woman job. It is in tune teamwork. We have to work all like a really well-resonated team. Now, let's go to micro neurosurgery, the history. Maybe all the listeners of this, my talk do not remember when microneurosurgery was born. In 1967, the first publication on microsurgical repair of peripheral nerve injuries was published by Smith at Walter Reed Hospital, 26 cases. At the same time, Dr. Kersey in California, he was performing also some microsurgical procedures on patients. But Dolenc in Vermont, he created a school for microsurgical training. Dolenc's school, Yashargil visited and tried to put the microsutures on very small vessels. And one morning in 67, Yashargil and Dolenc were talking in his office, and then the neuro nurse from Dolenc entered the room, and she said, "What is on? What is going on?" And Dolenc said, "Yashargil is leaving." But then she said, "Why she is leaving? He is leaving." Dolenc said, "Because he thinks that microsutures are impossible." And then again, neuro nurses help. She said, "Mr. Yashargil, we are human beings. We all have good and bad days." And this sentence from neuro nurse convinced Yashargil to stay, and on that very day, he successfully sutured the small vessels. That was the beginning of Yashargil's microneurosurgical practice. He went back to Zurich and started with the new beginnings in Europe with contrast microscope, with micro instruments, bipolar coagulation introduced by Mellis from New York. He introduced controlled stage suction and microsurgery workshops. So people were able to come to him and to learn microsurgical technique in the Yashargil's lab in Zurich. But Yashargil was very enthusiastic about these micro techniques and the possibility how to deal with small structures. And he put maybe too much work on the team. And that the critical moment in Zurich neurosurgery came. Revolt of the personnel. The director of the hospital invited different people from neurosurgical department and asked them, "What do you think? Is Yashargil too aggressive to his co-workers?" And do you imagine? Everybody had said yes. The last person who had to answer to this question was neuro nurse Diane, who was working with him. And she said, maybe people think they have to work too much, too diligently. But Yashargil is on the patient side, and he sees what the patient needs. And that's why I think he is not exaggerating. And this saved Yashargil, and he could continue with microsurgical work on the patient. Then many visitors came to Zurich and helped to transfer the model of working at neurosurgery to different countries. Altogether, 1,500 plus visitors in Zurich. So Europe was flooded with new kind of work, and also other continents. Confrontation with pre-microsurgical practice, it was not easy for those members who came to Zurich and learned the new way of dealing with neuro patients and to come home and to introduce this, because at home there was a whole team of old surgeons. They did not care. They could not accept, and that's why it was difficult. Pre-microsurgical practice was for aneurysms 6 weeks bed rest for those patients. And I was confronted with this also. And I said, but what is this? For me, it was just waiting for natural selection. That the disease eliminate difficult cases. And later on, classical neurosurgery was just dealing with those who survived. But for me, very important was that the doctors did not stop blaming the nurses that they were responsible when a patient died. This was not correct. And then at surgery, in pre-microsurgical era, when there was an aneurysm patient and the aneurysm ruptured with at surgery, they said, oh, that's the end. But with microsurgical era, higher magnification, control of bleeding, exclusion of the aneurysm. Of course, there were some surgeons in some countries, they put the microscope away when the bleeding started. The neuro nurses' responsibility for the patient during the 6 weeks bed rest in subarachnoid hemorrhage patients. This was injustice toward the nurses, toward the people who were in the hospital. And that's why the idea of active approach was born. Surgery in acute stage. Convincing factors of the team and other specialists was, if we remove a hematoma on the convexity of the brain, why do not we remove the hematoma at the base of the brain, which is even more dangerous? Then to open the lamina terminalis. With this, we could prevent hydrocephalus. And of course, with aneurysm clipping, we prevent further bleeding. Great help was, of course, with neuroanesthesia. With slack brain, we were able to operate more with less traumatism, almost atraumatic surgery. Then the story of nimodipine I leave to you, but it was very, very important at that time also. Then several meetings on SAH, SIH problems and early operations were in early 90s in Japan. With these meetings and our own experiences, many problems were solved. How to operate, how to remove the hematoma, how to wash out the clot, how to improve the circulation of CSF. But remaining problems are still here. Why an aneurysm occurs and how to treat vasospasm. This is on the beginning and at the end. So these problems still exist. We still do not have answers. Microneurosurgical operation is the most difficult part of treatment of patients with neurologic disease. Duration of neurosurgical operation might be from 1 hour for some simple aneurysm or microvascular conflict, but may extend to 20 hours. This was my experience in some AVM with enlarged central skull-based tumors and in repair of brachial plexus complete avulsion. And this is the problem. Long surgery, importance of video, politeness of the team is limited. At the time when we did not have yet video, the team was polite to the surgeon. What he said, oh, I'm doing this and this and that, they had to believe, but they did not see. They could not endlessly follow and help. So understanding of the steps of the operation via video is a must for good cooperation of the entire team. In critical phases of the operation, neurosurgeon should not turn his head from the microscope. Yashargi is saying, personal experience, turbulence in the blood, in the large and giant aneurysms seen through the thin wall, rupture possible at any moment. So highest concentration is needed. Cooperation of the team should be via video. Silence in the OR is a must. Slack brain is a must. And gentle pass of needed instrument to the surgeon is incredibly important. Questions are disturbing. So this is the behavior which should be achieved in the OR. Now, this is my personal opinion. Neuro nurses highly preferred over neurotechnicians. Maybe some people will not agree. And my answer is, why female? They are superior in multiple functions simultaneously. They are superior in gentleness, in adaptability, in loyalty, and in stress absorbing. Alternating of team members on each 2 hours is disturbing, is dangerous. Who alternates? Neuroanesthetist and also neuro nurses. And sometimes it happens also that chief resident goes to the phone because the other residents are calling him. So the surgeon remains alone. This was unacceptable for me, for our practice. the hospital organization is, of course, different in different countries. And vertical vista version horizontal is like order against the chaos. For instance, if anesthesiologists change every 2 hours and the previous team gives the report to the next one, and also the nurses, then the surgeon is alone, cannot function. And I have such an experience in another country. Anesthetists were changing, were rotating, the nurses too, and the chief resident was on phone, and the transverse sinus ruptured. So what to do? You cannot do nothing. You are like pushing on the machine, but the car doesn't go ahead. So where such an organization in a country exists, we do need pre-operational agreements with anesthetists, with neuro nurses, with scrap nurses. We do to inform people of expected critical moments. And we do need information and anticipation. Consider the neurosurgical OR as your church, sacred places where absolute attention is needed. In churches and sacred places, believers pray. In neurosurgical OR, all the members of the team have to be maximally focused. Private affairs should be left outside. And finally, success in the neurosurgical operation is the result of the team effort. Failure of the neurosurgical operation, in most of cases, is the responsibility of the captain of the team. Thank you to all neurosurgical nurses and especially scrap nurses, and also to you for your patience.
So much, Professor Vinko, for your very meaningful and informative presentation. And before we go into the comment time, so I would like to inform all audience that if you have any questions, so please write down in Q&A box. And so, can I call Professor Hirotoshi Sano? Are you here, Professor?
I didn't understand you well.
Hirotoshi Sano, Professor.
I don't hear you well.
Please unmute.
Yeah,
Yes, yes, Sano.
Nice, very nice the lecture. And I
Thank you.
am remembering the Luburiana's
声が小さくて聞こえないですよ。
Yes, I
Luburiana's
hear
life,
you.
and
Yeah.
and so and one maybe something I would like to say. We are in Fujita Health University. We have many nurses that invited at that time. One nurse is in operating theater. I am probably that she is the first nurse. Then I think that she cannot understand. Then I am, for example, the bipolar, and then I am taking by myself at that time. But she hold already, and scissors she hold already. And then later on, I asked to her, she said, I saw your video before the surgery, and I learned how what kind of the instrument you need. And so then I understand the next situation, and she is waiting to and holding your I needed. That is the best nurse for me, and nurse should be the such kind of the team. The and also Professor Yasagi said, Diane, and he uh, he just give the hand, and then Diane put the hand some instrument. That is almost always the what he needed. But the only the different time is that he thinks that, oh, I will change something. At the time he have to say. That kind of the communication is the best way for the nurse and doctors. And Vinko said also the same thing.
That's why I mentioned this. I have a personal experience. First, if I turn head away from the microscope to the nurse and I ask for something, in meantime, the aneurysm can rupture. It did happen to me once. For that reason, I do watch the aneurysm, which can rupture at any time. And on the video, the scrap nurse does see what is going on. I only say, give me the this and that. And then it is important for me to get the instrument into my hand with a very gentle touch. The men usually give it too hard. They hit my hand.
Like orthopedic.
That is disturbing. And that's why I prefer to have a female.
Yeah.
The men are not of that patience, you know.
Yeah.
And this is crucial. This is just one simple moment. And this is, of course, the most important in aneurysm surgery. But it is also important in long duration of surgeries, in AVMs. If you operate an AVM without bleeding, it's success. But if you have a bleeding, then again you are in jeopardy, you know. And when, for instance, you are dissecting the fourth nerve from brainstem to the cavernous sinus and through the cavernous sinus, it's a gentle structure. Just a small, too strong move may rupture the gentle nerve. And the scrap nurse does see that, and they act accordingly. What I hate the most when somebody is coming to the door on the operating theater and says, "Oh, and when you are going to holidays, my gosh, leave the personal things outside." And Yashargi also closed the door. He shut the door. No entrance, no exit. I mean, we have to behave. Maybe this is an exaggeration, but I agree completely with Yashargi. OR of neurosurgery is like a church, like a sacred place. I mean, complete attention. And we are, all of us is responsible, and all of us can contribute the necessary movements and gestures that no disasters is created by us.
Thank you, Vinko.
Thank you. Thank you.
Yeah. I see Professor Mahmoud Qureshi raised your hand. So do you have any comments, Professor?
Thank you very much. It's been, this is Mahmoud Qureshi. I'm in Nairobi, Kenya, in East Africa. Professor Dolenc, it's been an immense pleasure listening to the way you describe the environment and the ambience during surgery. I think there are new things that I have learned today that I was not aware of. I was not aware that Professor Yasagil actually was about to give up microneurosurgery on that particular day. And we must thank the neuro nurse Diane.
Exactly.
The progress that has been made in microneurosurgery as a result of that intervention by the neuro nurse, I think has led to what we now see as standard neurosurgical practice. So I think you've made a very, very important revelation to me, at least today. I was not aware. Thank you very much.
You know, many people are not aware that he wanted to leave Vermont. If the nurse of Donaghy didn't enter, he would leave.
Amazing, amazing. And what we see and all the instrumentation that has developed due to his enthusiasm and his approaches and aneurysm surgeries would not have happened perhaps, or would have been delayed significantly. So we owe a lot to that neuro nurse indeed. Yes, please go ahead, Professor.
My small comment on this: the nurses in Zurich, they prepared when they had a minute or two free time, the cotton paddies on the sutures for the surgery. So he had different sizes of these handmade by nurses. And they did not oppose this because they were aware of how important it is to put a small cotton paddy into one or the other corner and to proceed and to preserve the brain and not to damage the brain. I mean, we have to act in the same direction with the understanding of the structure we are dealing with. And this is, I'm sorry, with all due respect to orthopedic surgery, to the abdominal surgery and so on, but we are dealing with more delicate tissue. We have to be gentle. We have to be progressing accordingly and so on. There's no big cut, there's no big hit and so on. No. We are walking small steps ahead. And also Yashagi said, with help of neuro nurses, we can go slowly. And if we go slowly, we will come faster to the end. If we go one step ahead and two back, and again ahead and back, we are on the place.
Thank you. I have another comment which I would want your view, and particularly the views of our senior nurses. Over the years, and particularly over the last decade, I would say, there has been a move towards, I think it's a result of uplifting standards, certainly, but also competition, where hospitals are seeking accreditations of joint commission here and this, that, and the other, which is a good thing to raise the standards. But what has happened, and I'd really like the comments from the nurses and yourself, is a lot of the care that is provided to the patient by the nurses has been diverted hugely by administrative work that goes into writing and filling the forms and continuing to. And you go to some of those hospitals that are seeking that, you do your ward rounds, and you want the nurse, and the poor nurse is busy writing long pages in order to fit the requirements of the Joint Commission for International Accreditation of some hospitals based in the US or wherever. And I say it is fine to do that, but if you're going to, the nurse has a finite timeline in her schedule. If you take 60% of that into paperwork, you are stealing that work from the patient's care. I want to know what the nurses can do to regain that passion for patient care. And then perhaps the administration has to think about getting administrators to do that kind of work rather than steal it away from nurses' time. I would want to know your opinion on that.
You are completely right. I am 100% for individual care of the patient and of the problems. All what is coming from the side, this administration and so on, and to answer to or follow the algorithms, I think with due respect to the advancement, technological advancement and administrative advancement, but it is an overload, and it is really taking the neuro nurses away from the most important duty she has with the patient. You may have a nice and good papers and documents and so on, but the patient is not able to breathe, or has an epileptic seizure, or had whatever troubles. That's to find a compromise between these new advancements, new developments, and individual care. We should never forget that the patient do need individual care in any specialty of medical treatment, but in neurosurgical even more, because certain percentage of patients are not reasoning properly. They are reasoning differently. We are almost, with some patients, like to be at the psychiatric department. And who can cope with this better than neuro nurse at the department? Nobody. Nobody.
Thank you. Thank you. Any comments from the nursing staff on this development that I find troubling, I must say?
If I may say so, I would totally agree with your comments. And I see it especially, there are so many young nurses just out of school, not long out of school, and the older nurses are so busy doing the paperwork and filling out the forms that the young nurses really lack education in neurospecific things that they need to know. For instance, just yesterday, we had a patient that had a pituitary tumor resection and was in DI, but the nurse was drawing the sodium off of a line that TPN was flowing into. She wasn't getting accurate sodium counts and didn't put 2 and 2 together that the sodium levels were not accurate. And anyway, his sodium, the real sodium was in the 160s. And so, you know, I just see that as an example of the lack of education that needs to be occurring for neurospecifics and the younger for the younger nurses. And the hospital doesn't really support nursing education. Unfortunately, the hospitals want these designations, but they look at a nurse as, you know, a body filling a spot instead of a specialist, is which they need to be. Highly specialized care for our patients.
Thank you.
It's
Thank
like
you
a
for
tertiary.
That's very correct. You know, those people, those nurses, they need introduction. They need a lot of teaching, you know. And I am against the idea, as it happened in one hospital I know, where director said, oh, we will rearrange, we will organize nurses. They will be like stewardesses at the airport. Go to hell, go to hell. One day she will be a scrap nurse at the orthopedic surgeon. The other day it will be a neurosurgeon. This is, excuse me, stupid. This is stupid. We need people who will stay with us and whom we can teach. We can explain to them why this is necessary, why this is needed, and so on. And they have to feel that they belong to the team, that the team cannot function without them.
Right.
Absolutely.
That's
I really thank you for reinforcing that, because I have just last week, an example, when we were doing an awake craniotomy, and we had started this at a hospital, and one of the nurses, who's very brilliant, she said, oh my God, I really want to participate in this surgeries because it's so involving, so exciting, and it's something fresh. And she immediately became very good. And as soon as she became very good, I found that she had been replaced to become an administrator in another ward. And I said, what a waste, what a waste. So I really thank you for supporting my hunch that this is going in the wrong direction. And we certainly hope that there will be enough movement from the nursing fraternity to say, please stop this. We send nurses to, I sent 5 or 6 nurses from Africa, which is a very unique situation, to send them for neuro nurse training in Valencia, where my colleague works. They came back and we were delighted to have these specialist nurses working with us. And within 3 months, they were posted as the in charge of the obstetric and gynecology department, another one in the A&E, and it felt such a waste. And I now thank you for supporting my concerns, and I hope that the nursing fraternity will do some kind of revolt against this way of working. But I can only make my views and share them here. You've done a superb job by sharing some very, very innocent thoughts. Thank you very much, Professor. It's been a delight hearing you.
Thank you. Thank you.
Thank you, Professor. And I see Professor Vladimir Neves on the screen. So, Professor, could you give some comments? Professor Vladimir Neves. I see on the screen. Can you give some comments?
No, I don't hear.
Professor Vladimir Neves. I see
Atul, can you help me?
Vlad is muted. I think Vladimir is now he's unmuted. Yes.
I'm here, but I don't understand what's requested. I'm sorry for this.
Professor Benes, you please give some nice comments about the relationship of nurses and neurosurgeons, and the need for specialized neurosurgery nurses, need for trained neurosurgical nurses, and how you think a trained neurosurgical nurse can influence your operation. Please give some nice.
Certainly, Atul. No problem. I guess that Vinko has said almost everything, and he has put it very, very nicely. You know, I always had the feeling that the neurosurgeon is like a captain on the boat or on a submarine. You really are in command, but you cannot drive the boat alone. You need a team, and you must respect the team. And the team is as a chain. You know, the chain is as strong as its weakest member. So you need all the members of the chain to be strong and to give their own ideas, strengths, knowledge, whatever you say it. Neurosurgery is really not a single man, one hero, one pilot of fighter, you know, with who is not caring for collateral damage to fulfill the mission. That's not like that. We are now elsewhere, and we really are a team which must go forward as a block, not as individuals. We are not really individuals. Vinko, perfect lecture with everything what should have been said.
Thank you. Thank you very much.
The best thing that you said, Vlad, was the team is as strong as the weakest link. That was wonderful. The chain is as strong as its weakest link. So that is very important, that as a team captain, if you want to call it a captain, you have to see that there is no weak link in your chain. Everybody in your theater is like your family.
Exactly.
Every theater you love, you respect, have mutual admiration. They should respect your work. They should have confidence in your work. They should think that you are the best. Then only that camaraderie and friendship and family relationship will function in making our patients. You see, all this we are doing for the welfare of our patients.
There is one more aspect which I probably would like to mention. You must enjoy what you are doing. If you enjoy it, you do it well. If you enjoy it, you do not work. As Robert Spencer has said, that he hasn't worked for a single day in his life. And I can underscribe that. And each member of the team should be like that. So we must be seeking people who really like what they are doing, who really enjoy it.
They have to be proud to be the members of the team.
Of course. That's without saying this.
Yeah.
Okay, so should we move on? Yeah, please go ahead. Please go ahead.
We have one question in the Q&A box. So can I read the question, Professor?
Yes.
The question is, when aneurysm ruptures, you are sucking blood, suction tube get clogged with clots. How do you tackle blood collecting in operation field? I mean, mental stated technical. I'm not sure I read the correct question.
When I was still working, I operate a lot of cases in acute stage, simply because 6 weeks waiting, this will exclude the bad cases. And they were, many of them, those patients whose aneurysms ruptured during the operation. But that's why the even higher attention and prevention is needed to be able to cope with the bleeding, you know. And here is another important lecture task to neuro nurses. Neuro nurses, they had to be prepared that if you are not able to clip the aneurysm, you have to reconstruct the aneurysm, either with suturing or making the cuff clips or whatever. So they have to be prepared for microsutures when you have to do this reconstruction, or with bypass, it also may happen. So sometimes I said, if I don't get the instruments in time and in proper way, I said, I don't need assisting a la carte. So when I need a microsuture, it has to be at hand. Neuro nurse has to have it. She does not need to say, oh, hello, Anne, can you give me the suture number 10 or 11? It is in the that and that box. This is a la carte. You get fresh instruments. No. I need the instruments to be already on the table and to be ready at the time.
I have to add one more thing to the discussion, and many people in the audience would like to know that acute surgery, like, surgery was done in general after 2-3 weeks after aneurysmal rupture, but Vinko Dolenc was amongst the very first few people in the world who said that aneurysm should be operated in the acute stage. Is that correct, Vinko? Or?
That's correct. And I was also criticized in the morning, at the morning session. I operated a patient who had a rupture previous day during the night. And about 300 aneurysms I operated in the acute stage in that decade. Half of them were with ruptures during surgery. And one day in the morning, I was criticized. Why did you operate? You know we have to wait. I was really, excuse my expression, I was pissed off. And I said, dear professor, the patient is in room 16 at the ward, awake, waiting for breakfast. The operating theater is empty. Take the patient to the operating room, take the clip off, and wait another 3 weeks. Of course, you can imagine how he accepted this critic. But we lost many patients before we started in the acute stage. Now, of course, it's different. Now, endovascular treatment is somehow substituted a lot of microsurgical procedures. But this is another topic. I wouldn't enter it because I'm still critical of complete taking off from surgery. No, my conviction is that surgery has the place, and now also endovascular are realizing this. Again, help or according to the individual approach and individual meetings before any decision is taken how the patient can be treated with endovascular or open surgery.
Thank you, Professor. And we still have one more question. And the question is, do you have any experience or suggestions to influence the hospital management to have an updated neurological nurse when it's still not common to have one yet?
If I have one, I didn't.
She's asking Vinko, how do you take the help of administration to make experienced neuro nurses?
You know, at hometown, I was lucky. I was able to get nurses who were really very much enthusiastic about this kind of work, and then they prepare and they accept the newcomers. I mean, everybody, okay, almost everybody can learn how to deal with this kind of duty. Some people need more, some people need less time. But they have to participate actively with their will, that they like this. For them, as for no other member of the team, the work in the team should not be job, should be a kind of living in this time of surgery. Complete exclusion of anything else and maximal attention, as I said. With a bit of patience of the team members, the new members can be introduced. And of course, the difficult part is how to convince the administration, because the politics are mixing into everything, you know. No, give the profession the right to organize. We know the best how we can function the best. But when something goes wrong, then administration doesn't take the responsibility. No, look at them. Then they're blaming us. You know, no, this is wrong. We have to arrange our way of working, of cooperating and so on. Not that somebody else from the side will order us how we have to function. That's of course that's not easy, and it's. But if I have a person for whom I know that she will stay with us for, let's say, 2-3 years, fine, I'm happy. But I'm not happy if the scrap nurses are coming today to us and next day they have to go somewhere else. No, this is not acceptable. No.
Yeah, I see Professor Mahmoud raised your hand, right?
Yes, thank you very much. There was a question that had been put earlier about when an aneurysm ruptures and the sucker becomes blocked, what do you do? I think that was the question. Let me share my thoughts, which were drummed into me, and I then drummed into my neuro nurses. It was drummed into me during my time with Professor John Garfield, may God bless his soul, in England. And when I came back, I drummed the same to the nurses who were doing neurological surgery with me. And that was that in my theater, before I start an aneurysm, there must be 3 functioning suction machines. And because these machines are rare in the operating rooms, the nurses would become a butt of a joke. Oh, here is the neuro nurse who is now today going to ask for 3 suction machines. But believe me, when a suction gets blocked and you start spending time unblocking that theater, the brain may swell on you. So you have to have your 3rd sucker ready immediately. So that's the way that I was taught by John Garfield. I brought it to my neuro nursing, and initially they were the butt of jokes, but now they recognize when an aneurysm ruptures, you don't have time to start unblocking your suction machines. So 2 suckers available in the operating site, and a 3rd one available if one of them gets blocked. And that's been the philosophy for aneurysm. I don't know what you think, Professor Dolenc and Atul, but that was drummed into me by John Garfield. May God bless his soul.
I know Garfield, he was a good friend of mine too. I agree completely. And that's why I said that the female, they are better than men in multifunctions at the same time. So the head scrap nurse at the table, she sees how the the aspirator when the bottle is almost full, and she sees the video, and she said, "Okay, if we don't have another aspirator machine, please stop for a minute. Let's stop." And everybody knows we have to change it, and then we can function further. But to have a 2 or 3, of course. But again, the scrap nurse is somehow obliged and able to work with 8 people there. And they have to pay attention to what is going on. You see, that's, but it's important to not to lose the time, not to lose the time.
I want
Yes.
to make one last comment. Last comment on this session. We can go on to the next session after this. You see, my comment is that we said that the neurosurgeon is the captain. Neurosurgeon is the captain. I think, Vinko, and I want to ask you, I will say neuro nurse is the captain. Why are you saying neurosurgeon is the captain? I think Sano said neurosurgeon is the captain of the whole team. I think neuro nurse is the captain. What do you have to say?
Yeah, but you know, then neuro nurse or scrap nurse should say to surgeon from which side you have to dissect the aneurysm and so on. I hardly can agree with this. I think neurosurgeon is the captain, but we are, as Vlad said, all the members of the chain. But somebody is the first link, the first member, you know, and because I have the whole plan in my head, why I will do this from this side and why from that side and so on, because I have a better feeling watching, observing the situation directly through the microscope than anybody else observing it on the video. Because unless you have a 3D video, you have a better view. And you can see what the other people do not see or may not see.
Okay, do you agree, Vinko, that of course neurosurgeon will dictate?
I want to say one thing, and
Dr. Sano, just a minute. I am saying
this is not so, but we are trying to be a good surgeon.
先生よく聞こえないですよ。
But now they are trying to be a assistant nurse. Everybody is trying to better.
I don't. Something is disturbing. I don't hear. I hear a
よく
breeze.
聞こえてない。
Pardon?
Hello? Hello? Is
Yes.
今大丈夫です。It's fine.
Your microphone is not good. Atul, tell me.
Yeah. So the thing is, you know what? Of course, Vinko, I agree that the neurosurgeon will make the decision how to clip, which side to go, which side to not go. But of course, you know, he's the leader, but he should behave as he's, you know, belongs to everybody. He is a team member. He takes everybody and follows their opinion, the opinion of the nurse, opinion of the assistant. Of course, he has to, you know, nobody should keep on asking questions and question his, you know, strength and solidity. but he also has a responsibility that everybody is given due importance, respect, and power. Also power. What do you have to say, Vinko?
Yes, yes. I think it is normal this way, you know. As
Yeah.
it was said, the one has to take the decision how to take another further step, and the person who is the most informed and who has the plan, the whole plan in his head already prior to the surgery, and then adjusting it to the situation at the surgery. This is the neurosurgeon.
So I think, Vinko, that was a wonderful discussion, wonderful lecture from a wonderful man, wonderful surgeon, wonderful, handsome human being. And thank you very much. You may not know that Vinko was a basketball player during his earlier days. Tall, handsome, and efficient. So with that, we close this session and we move on to the next Master of Ceremony. Please take over.
Thank you. Thank you very much.
Yes, Professor Machini, so can you continue with the second session?
Okay, thank you, Professor Vinko, and all that has given a lot of excellent suggestions and informations regarding neuro nurses. And now we shall call upon Professor Irion to introduce Dr. Ariel for the second session. Thank you.
Can you hear me? Good evening to Eastern Hemisphere, and good afternoon to friends in Europe, including Dr. Goel today in London, and good morning to our friend that's joining us from US. I'll share my slides. I have prepared a few thoughts on the next speaker we have. It's a true delight for me to join the wonderful team of friends and colleagues from around the world to spread out the voice of the necessity and the importance of the role that nurses play. And I find it a dual team play. I don't see any success without all the team members being part of it, and those that have been part of the team being respected. I'll move fast and forward just to take this up, have it here. It's a true delight to have joined you today, and what is more delight for me is to introduce an outstanding individual in the field of neuronursing. Andrea Styner is currently practicing as a nurse practitioner in the University of Wisconsin. She started her education a few decades back, and that was with the University of Iowa, where now she graduated from her nursing bachelor's of science. And then moving forward, from there on, which is 1991, Andrea has been switched her practice, education, and career in Wisconsin. That's where she moved forward with graduate studies in Master of Science, postgraduate education, and then about 3 decades later, she moved on with studies in a program in graduate studies in PhD program. Is a well-renowned nurse in the field of neuro nurse in the United States and so on internationally. She has devoted plenty of time. I was reading through her curriculum vitae. It's amazing, and I was amazed in how to have the opportunity to read. It showed passion. It showed diligence and perseverance to get to where she is currently, and to show us that with work and love for what you want to do, you can achieve a great deal of success Andrea has been recognized through different grants and awards for her work. She has been and continuously is a member of not only local and national organization in US, but as well internationally, has served to various bodies, professional memberships, and as well in her local and a broader community. So her talk today is going to be what is the role, and she's going to give us some more thoughts in detail about the role of the advanced practice nursing. What is the history of the scope, which I don't want to spoil it, but to tell us how maybe how challenging it has been to grow from something that was nurse to get to the nurse practitioner in neurosciences. What is the role of the nurse as being part of the team member? And then what are the opportunities and the challenges to caring for the patients in neurosurgical and neurosciences world? Now, with that, I had my slides to end, but then when I realized that Professor Dolenc is going to be here, I pull out of my archives a few images. I'm not sure if Vinko Dolenc is around, but here he's lecturing Dr. Ali Krishnan, Fatih Sharbel. And this for us to be is, it's an international symposium in Helsinki, a well-renowned man of international dimension. So I give the moment and the place to Andrea. Andrea, thank you so very much for being with us today. And I look forward to having you share your passion, your work, and the steps to progress in the field of neurosciences. Thank you so very much, Andrea.
Thank you, Erin. So let me just share my slides. All right, thank you for that wonderful introduction. It's been such a great conference so far. So I will be talking about building a neurosurgery nurse practitioner role, the opportunities and challenges caring for neurosurgery patients as a nurse practitioner. And as Erin said, I am a neuroscience nurse and have been a neuroscience nurse since 1985. I would like to thank my esteemed hosts for the opportunity to speak. And I just have to move one thing here. Sorry, get my screen set up. For the opportunity to speak today, I am both honored and privileged. And so to build a neurosurgery nurse practitioner role, I will first be discussing the foundation. And the foundation of the neurosurgery NP role begins with advanced practice nursing. And then from advanced practice nursing, we moved on to actually primary care nurse practitioners. I will then be able to describe in more detail specifics to the neurosurgery role. I will focus on neurosurgery because that is what my role is, and that is what I do. And so this is Jim. And you've all taken care of someone just like Jim and his wife. His wife found him on the ground in their home. She found him with right-sided weakness and aphasia. On presentation at the hospital, the CTA demonstrated a left-sided intercerebral hemorrhage, ICH score of 2, in the area of the left basal ganglia due to a ruptured pseudoaneurysm from a left temporal arteriovenous malformation. He underwent emergent embolization of the pseudoaneurysm. So he had significant deficits from his bleed: speech, learning, memory, and of course, right-sided hemiplegia. Nurse practitioners have a unique perspective and role in the complex team of people it requires to intervene and guide a patient like Jim and his wife through critical care and then acute care, rehab, and beyond. How is it that the neurosurgery nurse practitioner role is different than a neuroscience nurse at the bedside? How is it that the neurosurgery NP role fits into this complex team to assure an optimal outcome for a devastating injury like Jim had? And so first of all, what is an advanced practice nurse? Well, the International Council of Nurses tells us that in order to meet the changing global population needs and consumer expectations, healthcare systems worldwide are undergoing transformation and face restructuring. As systems adapt and shift their emphasis in response to the disparate requests for healthcare services, opportunities emerge for nurses, especially for the advanced practice nurse, to meet these demands and unmet needs. And so under the umbrella term of an advanced practice nurse is the roles of a clinical nurse specialist, nurse midwife, a nurse anesthetist, and then the nurse practitioner that we're talking about today. So the International Council of Nurses goes on to say in their guideline that advanced practice nursing refers to enhanced and expanded healthcare services and interventions provided by nurses who, in an advanced capacity, influence clinical healthcare outcomes and provide direct healthcare services to individuals, families, and communities. As advanced practice nurses, as an advanced practice nurse who has acquired through additional education, the expert knowledge base, complex decision-making skills, and clinical competencies for expanded nursing practice, the characteristics of which are shaped by the context in which they are credentialed to practice. So this is very important. So you have the expert knowledge and the complex decision-making, but the International Council of Nurses tells us that you do this in the context in which you're credentialed. So for instance, you don't want me taking care of children, and I'm not credentialed to take care of children. I know nothing about taking care of children. I'm credentialed to take care of adults. The degree and range of judgment, skill, knowledge, responsibility, autonomy, and accountability broadens and takes on additionally extensive range between the preparation of the generalist bedside nurse and that of the advanced practice nurse. This added breadth and further in-depth practice is achieved through experience in clinical practice, additional education, which is a master's degree or beyond. And then, however, the core of the advanced practice nurse remains within the context of nursing and nursing principles. So the results from research conducted in Australia found that nurses in the field of advanced practice nursing exhibit patterns of practice that are different from other nurses. Findings demonstrate the capacity to clearly delineate and define advanced practice nursing. The significance of this research suggests that from a healthcare workforce perspective, it is possible to measure the level of nursing practice identified as advanced practice nursing to more clearly identify these roles and positions. So measurement of the advanced practice role, what they are doing to justify their existence is extremely important, and to also justify their impact on patient outcomes, which is what it's all about, is the patient. So this moves us on to the nurse practitioner, which is just one of those roles under advanced practice nursing. According to the International Council of Nurses, the concept of nurse practitioner was initiated back in 1965 in the United States of America based on a public health model to provide primary health care to children lacking access to healthcare services. The role was based on a person-centered, holistic approach to care for these children, with the addition of diagnostic treatment and management responsibilities that were previously limited to physicians and only physicians. However, it was distinct from the medical model in that it focused also on prevention, health and wellness, and patient education. Then in the mid-1970s, Canada and Jamaica followed the USA's development, aiming to improve access to primary care for vulnerable populations in rural, remote, and underserved communities. Moving on to the 1980s and early the 1980s in Botswana, as the country responded to healthcare reforms and the population needs of the country spiraled, a family nurse practitioner role was launched. This was followed in the late 1980s by 4 countries in the United Kingdom also developing a nurse practitioner role. Then in the 1990s and early 2000s, additional countries introduced nurse practitioners. The International Council of Nursing and the International Healthcare Community noting significant increased interest and development worldwide in the nurse practitioner role. Since its beginnings, the focus of the NP has evolved to include general patient populations across the entire lifespan. And this is not only in primary care, but it is also meeting the complex needs of the acute and critically ill patient in the hospital setting. But what about that hospital setting, that specialty care, neurosurgery specialty care? People that are here to take care of Jim, that have had a hemorrhage and all sorts of other neurosurgical problems. Well, we first need to talk a little bit about the scope of practice of the nurse practitioner. So the scope of practice for the NP refers to the range of activities, those procedures that they do, the actions and processes that an NP is legally permitted to perform. This scope of practice sets parameters within which the NP may practice by defining what the NP can do, which populations they can see and treat, and under what circumstances the NP can provide care. Furthermore, once defined, the scope of practice and associated competencies are linked to the designated title and form the foundation for developing appropriate education and professional standards for that nurse practitioner. The nurse practitioner possesses advanced health assessment, diagnostic, and clinical management skills that include pharmacology management based on additional graduate education, like we've talked about, a minimum of a master's degree, and the clinical education that includes specified clinical practicums in order to provide that range of healthcare services. The focus of NP practice is expert direct clinical care. So that is expert patient-based patient care, direct clinical care, managing healthcare needs of also of the populations, the individual and families in primary or acute care settings, with the additional expertise in health promotion and disease prevention. As a licensed and credentialed clinician, the NP practices with a broader level of autonomy beyond that of the general bedside nurse, advanced in-depth critical decision-making skills, and works in collaboration with the other healthcare professionals. The scope of practice for the NP differs from that of the generalist nurse in the level of accountability and responsibility required to practice. So importantly, around the world, where the NP concept is recognized, establishment of a scope of practice is one way of informing the public, hospital administrators, and other healthcare professionals about the role in order to differentiate the qualified NP from other clinicians who are not adequately prepared for NP practice or who have not been authorized to practice in this capacity. So briefly, in summary, they have a minimum of a master's degree or greater, license and credentials. The scope of practice is the range of the procedures, the actions, and the processes that they can legally perform. It's defined by what the NP can do, what populations they treat, and what circumstances they can provide care. And its associated competencies are linked to the professional standards and appropriate education. They provide expert clinical care, expert management of the needs in acute care settings, expert health promotion and disease prevention, autonomy, a broad autonomy, advanced in-depth critical decision-making in collaboration with everyone else, and then integration of education, research, and leadership in conjunction with the emphasis on direct advanced clinical care. So just like we heard earlier this morning, well, it's morning here, sorry, earlier today, you don't do this alone, you do this with a team. And so it's the integration of that leadership skill. So we're not talking about primary care though, we're talking about neurosurgery here. We're talking about Jim, who had an intracranial hemorrhage. So as the nurse practitioner, you need to have that expertise in neuroanatomy, neurophysiology, neuropathophysiology. What do you expect to see when somebody has a dominant hemisphere basal ganglia hemorrhage? What do you expect his clinical picture to be? What do you expect his deficits to be? What do you tell the nursing staff? What do you tell his wife? What are you expecting? If you're in the ICU, you have to know what's next for this person. And then patient management also. So ventilator management, hypertension management, the pharmacology of hypertension, the pharmacology of his other medical conditions, his diabetes, obesity, whatever those might be. Prevention of delirium, for instance, and just managing the whole person, holistic nursing-based care. It's really everything. And there's also the incorporation of guidelines and evidence-based medicine. The next point on our list of domains was that expert management. Well, we already talked about management in the last slide a little bit, but it's also that expert management of building systems of care for, say, a hemorrhagic stroke patient. So what system of care is in place? Do the EMTs know what to do if they come across a patient that may have had a stroke? What about the emergency room? Is there a system in place so that the emergency room is alerted that there's a stroke patient coming and they need CT available immediately? And then what to do for that person? The ICU nurses, the neuroendovascular suite. We have a person, an MP that works in our neuroendovascular suite, hypertension management, following guidelines like the American Heart Association puts out and being a comprehensive stroke center. All of these sorts of things that go into expert management. It is not in a silo at all. It's very complex. Lots of order sets and things like that also. And so health promotion and disease prevention, this is the guideline for that was put out by the American Heart Association for the management of the patient with an intercerebral hemorrhage. However, one of the points in this guideline is the prevention of recurrent intercerebral hemorrhage. And so I know that you can't read what this says. You can pull up the guideline, but this is a part also of being a nurse practitioner, is that health promotion and disease prevention. So advocating that they go home on adequate hypertension management, that they can afford, that they can manage, that they will do. Diabetes management, obesity management, communication with their primary care. And maybe it even goes on to a communication with the primary care setting of the importance of hypertension management so that people don't end up in this situation in your emergency room. Now, Jim had a pseudoaneurysm, but as we know, a lot of intracranial hemorrhages are hypertensive. Additionally, that broad level of autonomy, you have the education, the credentials, the licensure, the scope to act, to write orders, to improve patient outcomes, and you need to use your autonomy to the fullest of degrees. That critical decision-making, you have all the information in front of you, the labs, the CTs, the clinical exam. What other information do you need to make your critical decisions? Maybe you need to talk to his family. Maybe you need to talk to the pharmacist, being able to problem solve that. And in neurosurgery, often extremely quickly. Work collaboratively. You listen to the therapist, the speech therapist, the physical therapist, the social worker, all the consulting services to bring it all together. That is your job of the nurse practitioner, to bring everybody's viewpoint together, including the patient and their family, so that you're on a integrated path. And then integrating your education, the scientific literature that you can find that is available, and your leadership skills with your clinical skills to improve patient care outcomes. And we're going to talk about this more in just a moment, as well as the healthcare system. So back to some beginnings about neurosurgery NP role. This is a paper that was published in 1980 in the Journal of Neurosurgery. This woman was a nurse practitioner working with a neurosurgeon. And this was the first paper that I could find that talked about the neurosurgery nurse practitioner. She talked about the general duties that she was doing, working in the ICU, specific diagnosis that she was taking care of, such as subarachnoid hemorrhage, brain tumors, And then the working to be accepted as a nurse practitioner, not only with with nursing staff and the hospital, but also with the neurosurgeons. And it was an early and not a clear, an easy process. It was a difficult process. At that point in time, she saw that her vision was that the nurse practitioner would be doing a lot of research. Here in the United States, we have a fairly new addition to nurse practitioner called a doctorate of nursing practice. The doctorate of nursing practice is a practice doctorate and not a research doctorate. And this is what the degree, an additional degree that a lot of the NPs have now. It is a clinical doctorate and not a research doctorate. So I would say that most of the nurse practitioners actually are not research oriented, unfortunately. So this is Dr. Manisher Javid. He was the first chairman of my department of neurosurgery here at the University of Wisconsin-Madison Hospital. And he had a vision for how a nurse practitioner would integrate into his department of neurosurgery here at UW. And he hired his first nurse practitioner in 1992. And then I joined him in 1993. And this is Dr. Javid several years after his retirement, but it was still several years ago, and Dr. Javid is now passed. He was the most wonderful person, very wonderful. And so just like your leaders have, and just like we've heard about this morning, he had a vision, and that vision has come to fruition. He was a wonderful visionary person. And so then in 10 years later, in 2002, this paper was published, and this is a very important paper when you think about developing a nurse practitioner in neurosurgery role, because the objective by these authors was to improve clinical and financial outcomes for neuroscience patients by using an outcomes managed model of care delivery and 2 acute care nurse practitioners as outcomes managers. And these people were in the neurosurgery ICU, as well as on acute care on the floor. So their methods were that it was a pre-post design. So they collected data before implementation of these acute care nurse practitioners. And then they collected data after the nurse practitioners had been integrated into the system. The acute care nurse practitioners use an evidence-based multidisciplinary plan of care to manage all patients, all of the neuro patients. And so here is a bar graph that demonstrates that the patients managed by the acute care nurse practitioners had significantly shorter overall length of stay, and shorter mean length of stay in the intensive care unit, lower rates of urinary tract infection and skin breakdown, and shorter time to discontinuation of the Foley catheter, and also a shorter amount of time to first mobilization. The outcomes managed group was hospitalized 2,306 fewer days than the baseline group. And so in 2002, that was a cost savings in 2002 US dollars of almost $2.5 million. So their conclusions were that clinical and financial outcomes are improved significantly by identifying patients at risk, monitoring for complications, and having acute care nurse practitioners manage them. And then a few years later, the American Association of Neuroscience Nurses did a survey of what are the NPs doing out there? What does their role really look like? Well, one of the things that they found out was that nurse practitioners were doing a lot of procedures that may have traditionally been only been done by physicians. And so you'll see on this chart, they were doing ventriculostomies, putting in lumbar drains, doing lumbar punctures, putting on halos, and doing a lot of patient care management in addition to that. So we think about nurse practitioners managing people, but they are also doing a lot of procedures. This was not something that we really heard of in that International Council of Nursing document that we just talked about earlier. That survey then was the framework that the American Association of Neuroscience Nurses used to write their first scope and standards of practice for advanced practice nursing that has since been updated in 2019. And so what that scope and standards of practice says regarding nurse practitioners in neurosurgery is that they plan and coordinate interventions from an interprofessional perspective. And so we heard about you come from a nursing model, but this takes it a step further, that you need to keep your nursing model, but you also need to appreciate everybody else's, where everybody else is coming from and everybody else's viewpoint, and pull it all together. Functions across the healthcare system and works with diverse populations, initiates and facilitates quality improvement initiatives, facilitates, conducts, and promotes utilization of research activities in practice, develops education strategies and evaluates effectiveness of educational interventions, recommends and influences social and healthcare policies, also something we haven't seen, policies, provides consultation to improve care, and applies legal and ethical standards to complex situations. Now, something else that I want to bring to your attention on this slide is that the pictures of the people on the right-hand side, they're all nurse practitioners, and they all implemented their roles a little bit differently. So some go into the operating room and first assist, and some are only in clinic, and some are only inpatient, and some do it all. So for instance, the top woman works at Barrow Neurologic Institute. She worked with Dr. Sontag and works with Dr. Spetzler, and she works only with spine patients in the inpatient setting. The next person actually has worked with Dr. Reg Hade, who's the current AANS president, and she's worked with him for 20 years, and she does clinic, she rounds on patients, and she first assists with Reg for the past 20 years. I'm sure she has a lot of stories she could tell. And then the next picture is myself with a woman that she works in patient critical care neurosurgery. And then the next person also first assists with several different neurosurgeons. And then Virginia is also a nurse practitioner. That was the first nurse. She was the first nurse practitioner that was hired by Dr. Sontag at Barrow Neurologic Institute. And she is the leader of the nurse practitioners there at Barrows now. So how the role is implemented is highly variable, and you really don't get a feel for that by reading the scope and practice, which is very general. So we are talking about Jim, who had an intracranial hemorrhage, and there's challenges with that. You know, there's challenges. You are the one that the nurses go to. You're the clinical expert and you're the leader. So it's challenging to support the nursing staff in a very difficult situation like this. Jim, unfortunately, in addition to his bleed, had severe delirium. He was hitting, kicking, very difficult to control delirium, in addition to his speech and memory problems, which is a whole nother thing. So our patients and our nursing staff and the family look to us to solve these problems, and it's very challenging. But there's opportunity here also. You have the chance to make a difference in the lives of every single patient that comes onto your unit, is in a bed like this bed, and their families and the nurses who care for them, by using all of those things we talked about earlier, the guidelines and your expert clinical knowledge. You have a chance to make a difference and turn around these challenging situations. It's challenging. There's orders, always more orders to write, always more patients to see. There's always another daughter that wants to talk to you about their husband or their father. I mean, not their husband, but their father, whoever. There's always another family member to talk to. More pages, more questions, more things left undone. It's a 24/7 business. And you don't always know what to say, and you don't always have the answers. And sometimes that is very challenging. but there's also opportunities. All this while you're mentoring. You can see the nursing staff grow and develop. One day they will be the experts. This is a picture of me with one of the nurses who worked on an evidence-based project on delirium and took care of Jim. And she presented this work at a national meeting. And so through these challenges, you look at the opportunities. You're a clinical expert, but the challenge is there is no scientific knowledge to help guide what you should do. We do a lot of things that are not based in science, and I wish they were. And you need to measure your value, but how do you find time to do that? And how do you do that? But it's very important. So there's opportunities to add to the scientific knowledge and to measure your value, your importance, so it adds to the literature base. These authors were from Canada, and there's two nurse practitioners that implemented a brand new nurse practitioner role. Their responsibilities were just like mine. So they were clinically based, and they did advanced healthcare assessments, ordering, interpreting laboratory tests, diagnostic testing, ordering meds, except they could not order benzodiazepines and opioids, which I can do. They discharged patients. They rounded with the residents in the morning, so it was a teaching institution. Reviewed and updated the clinical plans, clarified questions on conditions. They went to the interdisciplinary rounds, communicated with the families, all the other providers, et cetera, et cetera. You get the picture. And so their role really focused on that continued open communication with all of the healthcare team, allowing for transfer of timely information to nurses' family regarding care plans. And 80% of their role was technically clinical, and 20% was divided amongst research, education, and leadership. And so, like I said, they used a pre-test, post-test design. And what they found was so the staff was interviewed before implementation of this role, and then after implementation of this role. So what they found was very positive perceptions of the communication amongst the nursing staff between the nursing staff and the advanced practice nurses, improved communication of the written plan of care, and learning opportunities of the nursing staff. Given the extremely positive perceptions of the NP role in the acute care neurosurgery setting, it is important that nursing research continues to produce evidence related to specific successes and influence of the NP role. Research focus on role enactment is needed to understand the uniqueness of the hospital-based NP role, replicating the study in the future to evaluate the impact and the sustainability of the role once it is even more established and recognized by leadership is recommended. And so after our discussion this morning, this study comes to my mind because these nurse practitioners were obviously had a lot to do with nursing education. And while many of us do nursing education all the time, it isn't always supported by administration, either for us to be educating the nurses or for the nurses to have the time to receive the education. So you are challenged. You are not the neurosurgeon. You are not the resident. You are not the bedside nurse. And sometimes you feel very alone, despite this huge team of people around you. You feel like the weight is on your shoulders. However, there are opportunities. This is a picture of Dr. Biskaya teaching in the neuroanatomy lab. You are the eyes, ears, and voice when the surgeon can't be there. And that is a really, really important role, because just like that study we just heard about in Canada, that fills the gaps by being in that role. The communication gaps, the patient care gaps. In order to accomplish your role, you need to be developing the nursing staff, the interdisciplinary team. You're giving them your knowledge so that they can carry it on. And this is just a picture of some of the nurses on my unit. And it is so important that they are learning from you and getting to be those expert clinicians. It's a very specialized field. And then in order to be able to do that, you need to develop yourself. You also need to be mentored as a nurse practitioner. Yes, formal education is very important, but also to take advantage of the teaching, that learning that you can get every day from the patients that you take care of, to learn from them. And then also helping others to learn. This is just a picture of me with a couple of my mentors, Joanne Hickey, and some of you may know Dr. Benzel. And then of course our patient Jim and his wife that taught me so much. So in summary, we have the foundation for the neurosurgery nurse practitioner role. It is there. And there's many ways to operationalize the role. Every situation has to figure out what's going to be best for them. The neurosurgery NP is a clinical expert and a leader. We need to overcome the challenges and take advantage of the opportunities. The NP role makes a difference in the lives of people and their families we care for. Every day, every patient, I see it up and down my hallway, what a huge difference it makes. The neuroscience NPs, neurosurgery NPs, need to measure and publish their impact that they have on patient care, patient outcomes, and the healthcare system. So I would like to thank you all for your attention. And this is just one more picture of the neuroscience nurses that I work with that we were able to go to a national meeting. Thank you. I will stop sharing.
Thank you so much, Dr. Andrea, for the wonderful presentation. And now it's time for comment time. And so can I call Professor Mahmoud? Do you have any comments, Professor?
Yes, thank you very much, Andrea. That really has been an eye-opener for many of us. Really, this is a profession or a role that many of us are not very much aware of, and it's very, very enlightening to see the impact that your category of nurse practitioner has made in the US. And I just wonder whether we have similar examples in Europe, because I know that in Africa, we don't have anything close to that. And in Tanzania, we've just begun to have, Tanzania is a neighboring country to us, more known for the Serengeti National Park and the Kilimanjaro mountain. But the nursing staff there through Gail Rousseau has managed to connect with the AANS, the AAN, and are taking the combined courses in order to improve the neuro nursing standards in that country and hopefully impact the East, Central, and Southern African region. But we don't have anything close to a nurse practitioner in our setting. And after we hear whether this is something, there are similar roles played by nurses in Europe and in Asia, I'd like to ask whether you might be able to influence this globally through the World Federation of Neurological Nurses. Is this affiliated to the World Federation of Neurological Nurses in any way?
So the World Federation of Neuroscience Nurses is affiliated with all neuroscience, neurosurgery organizations throughout the world. So all the countries can be members of the World Federation of Neuroscience Nurses. And so I think that would be a really good role for them. And they have just changed over presidents. There's a new president for them. Her name is Kathy Cartwright. And I can be in communication with her also. And maybe there's some room for collaboration with the World Federation of Neurological Surgeons also to help formalize neuroscience nursing education throughout the world.
I
And
think there
then if
needs
there's
to
a
be.
role for this, and then for in any country where there's a role for a nurse practitioner.
I think there needs to be globally from what I've just seen. And I said, you know, we've had the close collaboration with folks from the US, and a lot of nurse practitioners do come in those missions, you know, with
Right.
Paul Young from St. Louis and Bob Dempsey from where you are,
Yeah, yeah,
is well known for doing these missions.
right.
And a lot of neuro nurses come with them. But to
Mhm.
develop that to a standard that you've just described would be awesome
Right.
if it can be done globally, and if
Yeah.
there's some way of doing it. And you know, Nelson Oyesheku is now the president of the World Federation,
Yeah.
and Gail Rousseau is in the foundation of the World
Uh-huh.
Federation, with whom I have the privilege of serving. So it
Yes.
would be something that perhaps you can initiate through
Yeah, I will.
through Bob and Gail and
Mhm.
perhaps Nelson, and see how the WFNS can work with the World Federation of Nurse Practitioners for the overall benefit of standards across the world. Really, I'm really impressed with the kind of results that you've just shown us. And I would want to know from Vlad and from Atul whether we have, and from the folks in the Far East, whether we have something similar in terms of the practitioners that Andreas has just described to us. Vlad, Atul, and Sano, please, if you may want to give us some of your thoughts and whether we have something similar. Thank you very much for this very, very enlightening talk. Thank you.
Not
Thank
sure
you so
if,
much, Professor.
if Vlad is there on the screen, but as far as I'm concerned, I don't think we have anything similar. This category of nurse practitioner
Mhm.
is, I don't think it is even existent in this huge country.
Mhm.
And we can certainly learn from your experience, Andrea, and we can develop this category and go further.
Mhm.
As far as neuro nursing is concerned, you see, whatever you said was highly technical and highly contemporary, and the whole world has to learn from your experience, as Moody has said, that you should take the lead in training, in educating, and in formulating guidelines, and in taking this field further. You know, I'm more than neuro practitioner. I'm more interested in neuro nursing, particular,
Mhm.
and how this specialty can be, developed and prosper, is on people like you to take a lead in the whole world, you know. And I'm sure with the leadership of Yoko Kato, who has been spearheading Moody, as you know,
Yeah.
she has been developing this field of neuronursing for a long time. And she has developed neuronursing program in my own department. And I gave, how she invited my nurses, my technician, my boy in my theater went and spent some time in learning neuronursing. I think I give big credit to such programs where this kind of specialty is honed and the skills are developed and taken further ahead. What do you think, Moody, about this?
Absolutely. And that's precisely the reason that we got our nurses from Tanzania to start taking the courses and actually get a diploma so that they could become the trainers of trainers. Because we've just heard and we all know, without the appropriate and highly enthusiastic, passionate nursing who is going to assist you in your ward rounds, in your operating room, and in the follow-up, without that level of care,
Right.
our results in neurosurgery are never going to be the same as we would want. So I totally agree. I think, Atul, you're spot on.
Right. Because our patients, many of them, they can't talk. And it takes that expert knowledge to be able to sift through what is needed, what needs to happen to improve their care. Yeah.
I think you've just shifted the paradigm, and really congratulations on an excellent talk and really enlightening talk. So I think that paradigm needs to encompass all of us.
I know additionally that the International Council of Nurses has a nurse practitioner, I don't know, subset, whatever it's called, under the International Council of Nurses. And I know that they are very interested in helping to develop nurse practitioners throughout the world. And so that in addition with the World Federation of Neuroscience Nurses and the neurosurgeons also. It's a specialty. We need to start, we need more nurse practitioners, but we also need to start in the nursing schools because many young women are afraid of neuro patients. You know, they're afraid of people who can't talk, the degree of disability our patients have, and we need to start showing them the extreme positive of taking care of this patient population early so that we have a pipeline, because there's a lot of nursing issues that way too.
Precisely. Great. Vlad, are you there? Are you? Can you give us a perspective in Europe? I know it certainly didn't exist in England where I trained, but I don't know what happens in the rest of Europe. I don't know whether Vlad is still online.
Excuse me, Prof. Due to interest of time, because ACNN webinar will be on after this, shall I call upon Prof. Dolenc to give us the closing remarks?
Thank you very much. It makes my job harder to follow Andrea having this wonderful talk and then have Dr. Goel and then Dr. Qureshi. But if I might take 2 points, Dr. Goel is always open to advancements in the field of neurosciences, and he has proven it throughout the years. It requires a bilateral cooperation. Yoko Kato was there, and Professor Kano was there to help introduce the knowledge in the world, but it required as well the world to accept that message. And it happened with Arthur Goel first, among many others who followed, but it wasn't easy. And when it comes to Dr. Qureshi experience, I see him speaking highly. I don't know him, and I do have to hold myself of any bias, but he presents a wonderful lifetime of practicing education from England and then having to extrapolate that to Africa. I wish him every success in the steps that he has to take to have the practice that he has in his hands to move forward. If I am to put together these many thoughts, I see from the personal experience of Andrea that it took years to success. It didn't seem easy. And I want to finish my talk with US. I don't know for what reason the land of North America has been in the steps of the advancement well ahead of many things. Throughout the world, not necessarily in nurse practicing, we had Dr. Vinko Dolenc telling us that micro neurosurgery did not start where we thought. It started somewhere else and well advanced of that. But even in US, it has had to take times to success. It took not only Andrea, she's not the first. History has it that before her, many others were there. They tried harder, they tried in every different way, but they had to have the leadership to get along with those innovators, with those pioneers. You know, we have Dr. Goel here, and we have Dr. Qureshi, and we have Dr. Kato here, who were just a handful of those who would introduce. But I want to conclude my remarks by thanking Andrea, by thanking all of you here present, because without you, any step forward is impossible. And I very much would like to join the voice of Dr. Qureshi and then of Dr. Goel in trying to put this throughout the world. And maybe Andrea is going to take a lead. It's not going to be easy, but she has the perseverance. She has shown what it needs to have the passion and have the guts, if I am to put it in plain words, to move the wheels forward. And she has been successful into that. But she would need you. I'm just a small cog in a mechanism of many chains of reactions. But whatever I have in my hands, free will to have it and to join you, but it will need giants like you guys, like Dr. Kato, like Dr. Goel and Dr. Qureshi to welcome those bright, beautiful flowers of early spring like Andrea to join us in the field of neurosurgery, which is never easy. Thank you, Andrea, for being with us today, and to all of you for joining with the remarks and comments. Thank you, and I look forward to joining you in the very near future.
Thank you so much, Professor. And before we end the session, may I call Professor Dugokato to say a few words?
Thank you very much. So the two the guest speakers were wonderful, especially the Andrea. Andrea, thank you very much for the presentation. And in Japan, we have an increasing of the nurse practitioner number, but still the 500. So we need more expanding the number of the nurse practitioner, because in my department, we have 2 nurse practitioner since last April. Their support is very appreciated, because they can do so many high technical things. So I think maybe the 1/3 of our work, such as stitching out or suturing out the closing the bone, skull, and also the lumbar puncture, many things, they have a very high skill. And also that they need to become a nurse practitioner is 2-3 years more some advanced course.
Yeah.
And also that they need certificate, and they can do the more than nearly the 40 some skills. I think very admire. And also I think in terms of the working hours is limited in Japan or such as Korea. And also the task shift or task sharing of our work. That means is a nurse practitioner that help us a lot, I think. So I think the Moody said maybe that you can lead not only the US, but also the Europe and also the Africa, and also maybe the India, I think. So many want to learn, I think, to become such a nurse practitioner in the future. I really appreciate, and thank you very much for your great lectures, and congratulations. Thank you so much. Everyone, thank you very much for introduction. A very nice, nice talk. Introduction.
Thank you very much, everybody. We need to end here and see you again next time. Bye.